Good evening, and thank you for joining us on World Gynecologic Oncology Awareness Day for our educational webinar with Dr. Devin Miller. She will discuss how improvements in clinical research and care have increased available screening options and created more targeted treatment options against gynecologic cancers, such as cervical, ovarian, uterine, vaginal, and vulvar cancers. My name is Blake Belden, and I'm a member of VCU Massey Cancer Center's Marketing Communications team. Before we begin the presentation, I would just like to note that we'll hold all questions until the end, but please feel free to drop any questions you have as a comment in the comment section, and we'll address them at the end in a Q&A. Dr. Miller is a gynecologic oncologist at VCU Massey Cancer Center and VCU Health, where her clinical specialties include surgery and chemotherapy for gynecologic cancers. And her interests include robotic surgery, surgical education, and molecular diagnostics. She earned her medical degree at the VCU School of Medicine, completed a residency at Yale New Haven Hospital, followed by a fellowship at the Albert Einstein College of Medicine. Thank you, Dr. Miller, for joining us this evening. I will now turn it over to you.
Great. Thank you so much for the introduction. And yes, this is our Gynecologic Cancer Awareness Month and Day today. And so I'm so thankful to be able to talk about what's going on in our world right now for our patients. There's been so much happening over the past few years. And so there's just so much to talk about. And so I will kind of give a glance into what we've got going on, but there's so much more out there. So if you have questions, please feel free to ask. I'm so thankful also to be back in Virginia. I'm from here. I went to medical school here, and so we just love being able to collaborate with our different providers all over the state. And so, and teal is our color. I have no disclosures today. And so just briefly to talk about an outline. So we're going to start talking about what moving forward is looking like for all of oncology, and specifically our field, including precision oncology and targeted therapy and what that means. We're going to highlight some of our disease sites and talk about screening, prevention, and treatment. So ovarian cancer, endometrial cancer, and cervical cancer today. We're going to talk about addressing some disparities that we see in all types of cancer, and specifically our cancers. Talk about clinical trials and what's going on here at VCU at Massey Cancer Center. A lot of people ask us, what is precision oncology? What does targeted therapy mean? And how did you all, figure all of that out? So, we're kind of still, I think, at the very beginning of where we're going to go with all of this. It used to be that a lot of types of cancer, when we got a diagnosis, they were treated very similarly, or with just a little bit of variability between the stages. Now we have things called biomarkers. And biomarkers are characteristics of either the patient or the tumor that it's measured it's an indication of a biologic process or a pathogenic, meaning a not normal process, or a response to an intervention or exposure. And specifically, these can be lab tests, genetic tests. They can be characteristics or a genetic makeup of a tumor or characteristics of a patient. And these can predict if a cancer is going to respond to a certain type of therapy, either the standard of care, something that's more cutting edge. It can predict prognosis. It can provide for an individual plan for a patient. And it can definitely be incorporated into clinical trial design. And also can inform, even family members about things to look out for, or even the potential need for genetic testing. So this has been an exciting time for us as more of these become available. And so this has also shifted the way that we do clinical trials. So while we have standard ways that we do clinical trials in this country and throughout the world, and those are usually done in phases, we also have different types of trials that incorporate these biomarkers. So a basket trial, which is when an eligibility is determined by the presence of that biomarker rather than where the cancer is coming from. So in this picture, you can see a lung tumor, a liver tumor, brain tumor and a colon tumor all have the same mutation. So they are all eligible to receive a study drug in one trial. Whereas in an umbrella trial, it's the same site of disease, but they may be eligible for different medications due to the mutations that they have in each of those different types of tumor. So it's again, really exciting time in oncology because these things are happening very quickly and changing a lot about treatment. And then something else exciting that's been going on is the concept of immunotherapy, which you may have heard or seen commercials for. And this is essentially how we activate our own immune system to turn on to attack cancer cells. The reason that cancer is able to grow unchecked in the body is because it has very specific ways of evading the immune system, meaning it can mask itself to us, to our own body, recognizing that it's not normal. And so, for instance, these receptors that would normally fit together and would turn off our immune cells against the tumor, you can block that with certain types of medications. And so that way the tumor or the immune cells can recognize that the tumor is not normal. And it can help you, again, recognize that the tumor is not normal. And your body can actually kill the cancer cells itself, which is great and a very exciting concept in cancer treatment. And we have examples of all of these different types of concepts in all of our gynecological cancer sites. In ovarian fallopian tube cancer, uterine cancer, cervical cancer, and vaginal cancer, which is similar to cervical cancer, vulvar cancer, and even in a rare type of tumor called gestational trophoblastic neoplasia. So again, very exciting time for both the changing of standard of care of treatment and also the clinical trials that we have going on. So I want to start by talking about ovarian cancer because this is, again, so much has happened in the last couple of years to really change how we treat patients and also the prognosis of ovarian cancer. Ovaries go through a lot over the lifetime of a woman, typically, and ultimately, our population, about 1% to 2% of women will develop ovarian cancer. And ovarian cancer is difficult because it's unable to be diagnosed typically until there's some sort of surgical intervention. And so we can't typically biopsy it unless we know for sure what it is. So that means that 5 to 10% of women during their lifetime will have to undergo a surgery for suspected ovarian cancer of some kind. Now, not all of them will have it, but a surgery is still a big deal for a lot of patients. So 60,000 of these surgeries are done per year. And about 12 to 40% of women who are referred to us will ultimately have ovarian cancer. So that means that a lot of our patients that are referred to us for an ovarian mass or concern do not have a cancer. But it still means a lot of anxiety and a difficult time for these patients. And then just to bring up one more thing, that there is some emerging data that the majority or maybe half of ovarian cancer is actually coming from the fallopian tubes. And so we can lower the risk for that type of cancer with tubal ligation for contraception earlier in life or removing the tubes. And you can also lower the risk of these cancers with 4+ years of any type of hormonal contraception. And then this is one of those exciting things in this disease site now. The concept of hereditary breast and ovarian cancer is not a new one. However, we know that about 50% of high-grade serous ovarian cancer, which is the most common type, have alterations in some DNA repair genes. This is called homologous recombination deficiency, and that's a fancy term, but essentially this is very important because a lot of these are genetic related, sometimes in you as a person or sometimes in a tumor. And it's also an excellent target for treatment. And so we're going to talk more about that. The most common types of hereditary breast and ovarian cancer are the BRCA mutations. And as you can see, they have a lot of risks for different types of cancer over their lifetime. But for ovarian cancer, they have a 30 to 60% chance for BRCA1 and a 16 to 27% chance for BRCA2. And so this is something that we stress getting evaluated if you have a family history of ovarian cancer or a strong family history of breast cancer or these other types of cancers noted. But it's also important, again, for our patients who are referred to us with ovarian cancer already. And that's important because we want to make sure that they get the right treatment, but also that their family members get screened. You can manage the risk even without a diagnosis of ovarian cancer by having risk-reducing surgery. And this is very important because if a patient is diagnosed with a mutation because they have a strong family history, we can actually dramatically reduce their risk of getting these types of cancers, specifically ovarian cancer, by removing their ovaries and tubes by the age of 35 to 40 with BRCA1 or 40 to 45, or about that range with BRCA2. Interestingly, here at VCU, we have a surgical clinical trial evaluating, again, back to that concept of fallopian tube versus ovary cancer, the outcomes if these patients just have their tubes removed or they have their ovaries and tubes removed together. So this is an exciting concept, and so we encourage you or anyone you know with this concern to come have a surgical consultation with us for that reason. There's also other familial cancer syndromes that are important to see us for because, again, we can reduce the risk of a very difficult disease. And so what if you do have one of those mutations, but you're not ready to have surgery yet? There's not excellent evidence about how to specifically screen for ovarian cancer. It's very difficult to screen for. However, it's acceptable to see one of us and obtain ultrasounds and a CA-125 lab test, starting in the 30s. But ultimately, yes, we do recommend surgery at some point. So we can't prevent ovarian cancer, and we haven't really ever been shown to be able to do that very well in any of the trials that have looked at that. How do we treat it? So typically when someone is presenting to us, they have had some imaging findings, and we help them make a decision about whether surgery first would be better for them, followed by chemotherapy, or should they start with chemotherapy to get them a better chance of having a complete resection of their cancer? And that's what's the biggest goal. And so we help make that decision, and we review that with our partners and at a multidisciplinary meeting as well. So after you get surgery and chemotherapy, what can we do? So now what? Are we just done, or is there something else we can do? And we call this an opportunity for improvement because that was the standard of care for a very long time. And so this is where that personalized treatment comes into play. So the concept of maintenance therapy has been a big shift in this field. So that's extending therapy with the goal of prolonging survival without disease. So that's maintaining a treatment response. After all that treatment you went through in the surgery, and you have no disease at this point, you want to maximize that response. And also the concept of maximizing quality of life at this point. We don't want to give you something that also causes you to have a lot of side effects and toxicity. So there's several options depending on the situation. There's new medications called PARP inhibitors. There's anti-angiogenics like bevacizumab, which is something we can talk about, and even the concept of that immunotherapy that we talked about earlier. And also, where you have treatment matters. There's very good data that shows that with advanced disease in particular, there's survival benefits when patients have surgery with a GYN oncologist compared to other types of surgeons, and that in general, treatment at specialized centers for our types of cancers are associated with better survival. So it is important to get to a GYN oncologist. And briefly, I mentioned PARP inhibitors before. So this is a type of medication that's come out recently in the last 10 years. And essentially, it's a type of medication that targets an enzyme that repairs breaks in DNA or mistakes that are made during replication, which is very common in every cell when it replicates. But most people have an excellent way of repairing that, or In fact, many, many ways of repairing that. So these medications inhibit that ability for that enzyme to repair the DNA. So then essentially if the tumor cell, if we're talking about a tumor cell, can't repair its DNA, it will lead to cell death. In patients that have that type of mutation, homologous recombination deficiency, or that would also be BRCA patients, the tumors can't make that repair if that enzyme is inhibited, meaning that the cells die. And that's a really complicated mechanism, but essentially it means that these PARP inhibitors work really well in these patients with these specific mutations, either a genetic mutation that's been passed down to them, or even if the tumor has its own mutation. So that's very exciting. And that has led to an immense amount of FDA approvals for medications in ovarian cancer for the last few years. And as you can see, previous to this, it was maybe one drug per decade for a long time. And now this acceleration has been going on, which again is extremely exciting. And this is a very busy slide and it's very complicated, but just an example of what's been going on. So SOLO-1 was a study that was done on BRCA patients. And they were given that maintenance treatment with a PARP inhibitor after they finished their chemotherapy. What we're looking at here is there's two lines here, and these lines each represent a type of patient. So the top line measures the patients that received the study drug, that's a PARP inhibitor, and the bottom line measures what happens to patients who did not receive that medication. So the important part of this slide is that at 60 months since the beginning of the study, 50% of the patients who received that medication have not had a recurrence of their cancer, whereas only 21% of the patients who did not receive the medication have not had a recurrence, meaning that 5 years out from finishing their chemotherapy, 50% of these patients with advanced ovarian cancer did not have their cancer come back. And as you can see, the difference here is astounding. And so this has been an incredible breakthrough in this type of cancer. And there have been many different studies looking at different PARP inhibitors in this type of population. So we're very excited about this information, and there's a lot of ways that we use it. So here at VCU, we test for those hereditary breast and ovarian cancer syndromes at the time of the confirmation of diagnosis. And that's typically a blood test. And again, we do this either at the time of the hospitalization for the patient's surgery. So that means literally you would have your surgery for your ovarian or fallopian tube cancer, and then within the next few days in the hospital, our fantastic nurse navigator would come speak with the patient about the findings and the recommendation for the testing, and actually draw the labs right there and send them off. And if the patient is not having surgery first and instead having chemotherapy, we would do that at the time of initial consultation once we have confirmation of the diagnosis. And if this testing is negative, we can actually send the tumor directly again for the specific testing, and that also helps us to make these plans. So we want these results returned early in treatment so that we can help make these really exciting treatment and maintenance therapy decisions, and again, inform clinical trial eligibility. And this is awesome because we also have a pharmacist and dedicated nursing team that helps us to coordinate this and start these medications if you're eligible. So it's a very exciting time in GYN oncology. And here at VCU again with in ovarian cancer, we have 6 trials currently open, and they're both in the upfront, meaning at that initial point in treatment, and also in the setting of recurrent cancer. We don't have time to talk about recurrent ovarian cancer right now and everything that we have going on there, but if you can imagine from what we've talked about just in the upfront setting, how much innovation we also have if the cancer does recur. So it's brought a lot of hope to us and our patients. And so again, just a really exciting time in this disease state. And then to talk a little bit about uterine cancer as well. Endometrial cancer is on the rise in the United States. And You can see in 2007, it was, responsible for about 39,000 cases. And now in 2017, we're seeing 61,000 cases. So that is a huge increase. And, the other problem with uterine cancer is that we are seeing a disparity, and I didn't have enough time to go into this in detail, but in terms of the differences in the types of cancer, the stage, and the outcomes for happening to patients of different racial and ethnic groups. And so this is very important and a huge interest of a lot of our research here at VCU, especially in uterine cancer. One of the concepts in endometrial cancer that has been new over the past few years, starting about a decade ago, was that doing specific research on these tumors has revealed that there's basically 4 distinct categories of endometrial cancer. And this matters because we're finding out over time that they respond differently and they act differently. And so it's not just about the stage and what type of cell it is, it's about how it looks at the level of its molecular signature, which is, again, getting back to that precision medicine. And so, depending on what type of tumor it is, most patients are going to have surgery. Some may need chemotherapy, radiation, or a combination of that. And very exciting time in endometrial cancer as well is the concept of immunotherapy here as well, which we talked about earlier. Here at VCU, again, we don't have time to get very detailed about it, but we have the concept of minimally invasive surgery, which is really been adopted as the standard of care if possible in uterine cancer, which means that even for cancer surgery, you can have a very extensive staging surgery for uterine cancer and move the uterus, ovaries, and tubes and cervix and perform biopsies through 4 to 5 small incisions and actually go home the same day. We also utilize the sentinel lymph node algorithms, and that means that instead of removing all of the lymph nodes in the pelvis and the abdomen to ensure that there hasn't been any metastatic spread, we can actually use a specialized technique to just remove a couple of lymph nodes that will tell us whether or not there has been any spread, and that avoids the significant side effects that can come from having a significant amount of lymph nodes removed. So this, again, has been an exciting time in endometrial cancer. And again, we have many clinical trials that we're going to talk about that are really moving the field forward. And also, sometimes we recommend radiation therapy, either before or after treatment or after surgery. And the concept of brachytherapy, which is delivering a high dose of radiation to a very small area to prevent a recurrence or to treat a tumor. And we have a really expert team here. Just wanted to highlight a few clinical trials that we have going on. So the first one, GOG 3053, and we have a lot of numbers and letters here, and don't worry about that, but essentially the first study is looking at the addition of that immunotherapy to chemotherapy in patients with newly diagnosed high-risk endometrial cancer after their surgery. And so that could give access, potential access to an immunotherapy, again, which we talked about can target some very specific biomarkers in the tumors. And so it's a really exciting trial talking about potentially changing the standard of care. Similarly, we have NRG GY018, which is also a randomized controlled study looking at the addition of immunotherapy, that pembrolizumab, to standard of care chemotherapy and this is in the situation of patients who have not completely resected disease. So that's always a difficult situation to be in, and patients often have a lot of questions about what that means. But this trial means that you're still eligible to potentially receive, again, this immunotherapy early on in the process. And finally, GOG 3055, and this is a randomized controlled trial again, phase 3, and this is maintenance therapy. Again, we talked about that with ovarian cancer before, and so this is taking that concept to uterine cancer, and that's with this medication called selinexor versus a placebo after chemotherapy for patients who have, again, presented with advanced or recurrent endometrial cancer. And even patients with carcinosarcoma type tumors are eligible, and so these are all really exciting trial designs for our patients. And then I also wanted to talk a little bit about cervical cancer, which has been another tumor with an extreme growth in the data over the last decade, and has been a very exciting time as well. I just wanted to touch briefly on the fact that cervical cancer, there are a lot of risk factors for this tumor, the number one being exposure to HPV. And HPV is a virus that's quite ubiquitous, we know that, and it's the reason why we have screening. And so the number one risk factor for cervical cancer is never having been screened for cervical dysplasia, meaning abnormal cells in the cervix or precancer or cancer itself. And that can be a result of poor access to healthcare and low socioeconomic status, and that again is where those healthcare disparities play in. And again, we don't have time to get into it, but today, but there is so much going on at VCU to help with the access to screening and to getting treated for these pre-cancer conditions to avoid ever having to be treated for cervical cancer. Another risk factor is history of cervical dysplasia, which is that those abnormal cells, sometimes precancerous cells, a history of having abnormal pap tests in the past, depending on the sexual history of the patient, a history of sexually transmitted infections, which are associated with HPV infection, history of anogenital warts, just being immunocompromised in general, because then that HPV virus is able to change the cells in a way that can lead to that cervical dysplasia or precancer. Smoking is a big risk factor for both dysplasia and cancer. And rarely history of in utero DES exposure, which was a medication given years ago. So if we don't prevent cervical cancer for reasons like not having appropriate screening or different types of tumors that didn't initially present during the screening period, we have excellent treatment options. And it really depends mostly on the stage and the type of tumor again. And so when we first see a patient with suspected cervical cancer or confirmed diagnosis of cervical cancer, we evaluate that stage and the optimal treatment options. And this is going to involve things like specialized scans, biopsies, examination, and it can seem overwhelming in the beginning. And I think what's hardest for us when we work with our patients is, and this is for all types of cancer, but particularly cervical cancer, is patients want to get their treatment, the day that they meet us. And the most important thing with all, when I meet all of my cancer patients for the first time, is we're going to do this as fast as we can safely, but we have to get it right. And so sometimes that means that we have to take a minute and get a lot of imaging studies done, and also we may need to wait a few days to get the exact answers that we need. And treatment can be surgery, and in certain circumstances we can even spare fertility for these patients, not all, but some. We may use radiation, chemotherapy, we have clinical trials, and we may have a combination of all of these things, and in particular that immunotherapy that we talked about before. Here at VCU, I just wanted to highlight a clinical trial. So we, in the upfront setting, have GOG 3047. So this is for high risk or locally advanced cervical cancer, or stage 3 to 4A cancer. And that utilizes chemoradiation, again, randomized controlled trial, meaning you may get access to immunotherapy at the time of treatment. And this is also given for a time period beyond the end of the radiation treatment. And the exciting thing about cervical cancer is there are, again, everything is changing very quickly here. There are many ongoing current and future trials and FDA approvals happening very quickly. In fact, we're getting emails daily about new trials coming out and the suspected FDA approvals that are coming very soon. And again, I wanted to highlight our radiation oncology team, which here offers the most advanced techniques to help control the disease, help with symptoms, and they're also excellent at minimizing our side effects that we can have from radiation, which is also very important to our patients. So I just want to highlight their contribution to what we do because it's so important. And again, I wanted to touch back on how important this immunotherapy can be in cervical cancer. And so when I talk about it, what I mean is the concept of the clinical trials that we're looking at now, a lot of the times, is that we are kind of putting all of the factors about these tumors together and making that personalized treatment plan with those biomarkers. So if the HPV caused this precancer and ultimately the cancer, how can we kind of harness that, the fact that HPV was able to evade the immune system, and how can we turn on again the immune system to helping to target the cancer cells within our own bodies. And so part of that is giving the radiation and also, chemotherapy sometimes to help that radiation work, but then also maybe giving immunotherapy at the same time to, again, help the body unmask those cancer cells and let our immune cells take on part of the treatment of these cancers. And specifically in cervical cancer, just going beyond immunotherapy, there are new and exciting things happening. So there are targeted drugs that are not immunotherapy, like I said. They are actually antibody conjugates, meaning that they target specific factors within the cells. So in cervical cancer, a lot of these cells express something called tissue factor. And so there's even this drug called vedotin, which targets that receptor on the cell, is able to get inside the cell and actually causes the cells to stop replicating and to actually die. And they can also interact with other immunocells and also other adjacent tumor cells to cause cell death. So this, again, is a very exciting concept, especially if patients already received immunotherapy and they need to look at a different option. And so this is a really busy slide about a clinical trial that was done on this specific medication called tisotumab. But essentially, it's a really exciting thing because these patients who had advanced or metastatic cancer were given this type of drug, and it was seen that they did have a good response, and again, with minimal side effects. So here at VCU, we actually, again, have a randomized clinical trial of this medication, tisotumab versus standard of care chemotherapy, again, in second or third line recurrent or metastatic cervical cancer. So this is for patients who have recurred or progressed through other types of treatment. And again, we still have an option for them. So again, this is a really exciting development and again, an exciting time in our field. I just want to highlight the fact that we, again, have a lot of clinical trials here, and we have a lot of clinical trial experts. And so if you are looking for a clinical trial for yourself or for a family member, a friend, anyone you know, we have a website, which is, again, I put up on the screen now, where you can actually access all of our open clinical trials right there. And it's actually really simple. It will take you to this website. You can click on the site of disease that you're looking for a clinical trial and just click search. And then it will, you'll be able to see all of the open clinical trials in each disease site. And you can actually click on them and get more information. You can see if they're enrolling. You can find out who the primary investigator is, and how to get in contact with us about it. I just wanted to highlight our team specifically. So there are 3 GYN oncologists here. So Dr. Randall is our division director and a clinical trial expert who's recognized internationally for her work. And so she is an excellent resource that we have here to be able to provide our patients with cutting edge treatments and access to these excellent trials. Dr. Sullivan is also one of our GYN oncologists and is also very interested in clinical trials, and again brings her own expertise in that area and also surgical expertise as well, as we all do. And then I'm the 3rd GYN oncologist as well. Dr. Fields is our radiation oncologist. Dr. Gordon also is here and has excellent clinical trial experience and provides even some additional clinical trial options in the phase 1 realm, which we can talk about. And then we have an amazing clinical research nurse named Sonia Washington, who is just an incredible asset to our team and our patients, especially when we're screening for clinical trials and getting to know our patients who are interested. We have multiple care center locations as well, and we have a direct line for patients wanting appointments or for new referrals. And so with that, I'd like to take a minute to say thank you and ask if there's any questions.
Thank you, Dr. Miller. A lot to unpack there, so appreciate you giving this presentation. We'll open the floor for a little Q&A. We'll read anything that someone submitted in the comments, and we had a few submitted in advance, so we'll read those first. Is it better to seek care for gynecologic cancers from a gynecologic oncologist rather than my regular OB-GYN?
That's a really excellent question. So our OB/GYN colleagues are really often how our patients get to us. So they are excellent at seeing you and evaluating your symptoms, and if they're suspicious and they do their own workup with imaging or lab tests or an examination, they often decide that the patients need to come see us for further care, surgery, or treatment. But if you have a diagnosed GYN cancer, there is evidence that yes, patients do survive longer if they're treated by a GYN oncologist. But again, our OB/GYN colleagues are really excellent about sending patients to us that they have any concern about.
Okay. Who should consider getting genetic testing?
Great question. And I, didn't have time to get totally into this presentation today, but there are a lot of reasons for genetic counseling and testing. We have an excellent genetic testing and counseling program here at VCU, and we work very closely with them, as you can tell by the amount that we that matters for treatment and for our patients. But for us specifically, any patient with ovarian cancer is going to be referred for genetic testing, partially because of all those reasons that I mentioned about treatment, but also because, again, of that high rate of genetic reasons for the tumor. So there are excellent resources about how to know if you should be tested for a genetic reason for a cancer or to see if you're at risk. The NCCN has an excellent tool for this, and there are multiple online resources which I can provide, but basically, if you have a strong family history of cancer, for me, breast and ovarian cancer, it matters. Talk to your doctor about whether or not you think that, whether or not they think that you should go for testing. The other syndromes, that we deal with a lot are something like Lynch syndrome, which is a hereditary colon cancer syndrome, which is a high rate of endometrial cancer as well. So again, if you're concerned and you have a strong family history, talk to your primary care doctor, your OB/GYN about whether or not they think you would qualify for testing.
Okay. So you mentioned this a little bit already, but could you kind of highlight some of the controllable risks as well as some of the uncontrollable risk factors?
Great question. So, in terms of the different types of cancers, they vary a little bit. So if we're talking about ovarian cancer, obviously we can't control, our genetics, so our specific genes. And if we have a mutation that may, at some point in life, potentially cause an ovarian cancer or breast cancer or any type of cancer. But if we are worried about a family history, talking to your doctor and getting that testing would allow you to potentially control your risk, because if you were found to have a genetic reason for those familial cancers, then you could have surgery to reduce your risk. And again, that can be done by one of us. It's a specific surgery, and it's usually same-day surgery, and then you can reduce your risk again from those numbers we were talking about on the order of 20 to 60% down to like 1 to 3%, which is really amazing. The other things to look at for things like ovarian cancer would be if you have a tubal ligation, meaning if you have your tubes tied at the time of a delivery, you can reduce your risk by 50%. Having been pregnant or breastfed 4 to 5 children during your life actually reduces your risk. Also, taking any form of hormonal contraception, meaning birth control pills, anything that prevents you from having a regular cycle within your ovaries for about 4 to 5 years during your life reduces your risk. Anytime you cannot smoke, that is also good at preventing almost all types of cancer, but specifically ovarian, cervical cancer, and endometrial cancer. And then seeing doctors regularly is so important, and that can also be part of controlling your risk factors. And there's a lot more we can talk about with risk factors for cancer, but again, being within care and getting your screening if you need it and when you're supposed to is so important.
Okay. So you definitely mentioned what type of clinical trials are now available, but more importantly, why should women consider these clinical trials?
That is an excellent question, and the short answer is that there's so many reasons, and the long answer is that clinical trials are amazing because they are what is moving our field forward. And I think a lot of times when we think about the words clinical trial, it can be a little bit scary because it sounds like it's experimental and nobody wants the feeling of being experimented on, and we're very sensitive to that. However, what clinical trials can give you is access to medications that we know probably are going to work to help with a certain type of tumor. And we don't always know, we're testing it, but it can give you access to a medication that's the standard of care plus another medication. And that's a really cool concept that otherwise a lot of patients wouldn't have access to. And frankly, they have access to, a research team, research nurse, a specific protocol for, when they do everything. And everything is watched really closely by not only us here, which we always do, but at, a national trial level. And then the other exciting thing about all of it is that you have the ability to potentially help future patients move towards the future, oncology into the future for future patients. And, some patients, that's really something that's appealing to them. But I think overall, the thing that scares, most patients again is that idea of that experimental word. And we understand that, but knowing that it really is, you're going to always get the standard of care on a trial. It's just that you may even be able to move beyond.
So you showed us the website earlier in the presentation, but would you also suggest patients ask their doctors about clinical trials?
Absolutely. So you can probably tell that we're going to be talking about them a lot with our patients here, But if you're being treated somewhere else, or if you are kind of just starting the process of oncology care or know someone that does, absolutely ask your physician, your primary care doctor, your OB/GYN, your GYN oncologist, anywhere about talking about clinical trials, because again, we have the ability to see patients and talk to you about them even remotely sometimes. It's a really amazing thing that you can find out a lot about, again, through the website, but also, like you said, through your physician.
Okay, great. What should patients know about cancer and fertility?
That's a really great question. So I think this is one of the hardest things that any oncologist would probably say that they deal with. And we treat a lot of young women in GYN oncology. And so what's important is that you ask. If you're being seen by one of us or by another oncologist for any type of cancer, we want to know what your desires are, what you see your future as being, because we have a lot of options for our patients. We work with an excellent reproductive endocrinology and infertility group here who's able to see our patients very quickly. And so if we see a patient for a consultation for a new diagnosis of cancer, we can refer them to see that group quickly, and so they can help them review their options depending on what we recommend. And there's so many options for our patients. Like I said, specifically our patients, but also patients with other cancers. But like I said, sometimes you do have to be an advocate for yourself. And I want to make sure that patients know that they should ask and that it's important. And that it's another part, of what we do. And what I always say is what's important to you is important to me too. So,
Right.
you should ask.
Okay. Is the HPV vaccine effective in preventing cervical cancer?
That's a really great question. And I did want to touch on that today. So I'm glad that this question came up. The HPV vaccine is very effective in preventing cervical precancer, so cervical dysplasia, and also cervical cancer. There are multiple clinical trials that have looked at this, and our most recent data suggests that it is probably about 90% effective in preventing cervical dysplasia and cancer. And so we highly recommend it. And also, there is some emerging data that it may also help to treat cervical dysplasia or precancer with the addition to that standard of care. So that's kind of, again, all of this data is coming out since those trials have been done, starting decades ago. But again, our hope is that eventually there is no more cervical cancer because we're able to prevent almost all of it with these vaccines.
So you mentioned a little bit about some screenings. Can any of these cancers be detected through a Pap test?
It's a great question. So Pap test is really the screening test for abnormal cervical cells and precancer. A Pap test is something called cytology, meaning it just looks at individual cells. If the Pap test is abnormal, which is done for routine screening, then sometimes your doctor will recommend a biopsy. And a biopsy can determine if someone has cervical cancer. The other thing about Pap tests is sometimes if they have a certain type of abnormal cells, they may give us a clue that there could be an underlying uterine cancer. So yes, it can help in the detection, but the real purpose for a Pap test is prevent even getting to that point, and that's again our goal for all of our patients.
Okay, great. Well, Dr. Miller, I think that's all the questions we have. So it was such a pleasure having you join us for this discussion. We were able to learn a little more about the advanced treatment options and clinical research regarding gynecologic cancers at VCU Health and Massey Cancer Center. To the audience, if you want to learn more about Dr. Miller and Massey, you can visit vcuhealth.org or follow at VCU Health and at VCU Massey Cancer Center. Once again, thank you, Dr. Miller, and to everyone who joined us this evening. Have a great night.
Thank you.